So for the distal osteotomy of the first metatarsal, I start with marking my landmarks. This is the area of the TMT1. This is important for me. And then I mark for me the plantar aspect of the metatarsal bone, especially in the midshaft here, it's curved. So you have to be sure not to be too far plantar with your running of your key wire. So this is the areas where I would like to have my screws in, and then I mark my position, the position of the osteotomy. So this is the head, just proximal to the head, extracapsular. This is the area. To be sure, I take an X-ray. Yeah, this is my position, and I like to do a transverse cut. For this, the entry point is midshaft, so you can tilt the burr to proximal and to plantar. This burr is 2.2 millimeters in diameter. So we have a bone loss of 2.2 millimeters. To avoid an excessive shortening is to tilting the burr more, with the tip more to distal. Usually 10 degrees is the amount what I like to have to avoid excessive shortening. There's some cases, maybe revision cases or other cases, where you would like to have more lengthening. So just go more than 10 degrees, maybe up to 20 degrees tilting of the burr towards distal. And then you have the plane. In this plane, you shift your head. So you not only shift the head in the frontal plane, you also shift the head towards distal. This is a way to avoid the shortening or to achieve lengthening in specific cases. There also is the possibility, if you have a hallux rigidus or the other case where you would like to get a shortening, you can try to just stay perpendicular to the metatarsal. So by that, you get a shortening at least of 2.2 millimeters within burr, which is wider. This is a 3.0. This is also possible to take just a burr which is wider, and you can take off more bone and get just shortening without tilting in one or the other directions. A midshaft incision. And then check the position of your burr. The position is good. Tilting about 10 degrees to distal. A good place where you can point on is the head of the second metatarsal bone. I like this position of the burr, the tilting, and now I can go directly into the bone. First and second cortical bone. You can check it again. You're in a position where I would like to have it. You have the tilting, and to avoid additional shortening, and then work from inside to outside just till you lose the contact to the bone. As soon as you lose the contact, you can stop it. Now the dorsal part is cut, and you go straight plantar. Yeah, I think we're done. Now you can check it with the X-ray. The osteotomy is done. Without the burr, it looks like this. Yeah. So now you can mobilize it with a clamp, a rasp, and shift the head in the desired position. Take care of the rotation, take care of the plantar and dorsal positioning. The benefit of this transverse cut is that you avoid a more proximal directed plantar cut. Especially if you're coming in with your screws, you have much more bone stock to fix it on the second cortical bone with the transverse cut than the plantar cut. In some cases, the rotation should be controlled. In those cases, I bring in a key wire in the first metatarsal head. Then I can handle the rotation much more easy between this and this, like a joystick. So and then I have my clamp to do the shifting. Then I go in, do my rotation control. It's not much shifting, but we don't have a big pathology of the intermetatarsal, but we have a good position of the head now. You see the nearly 90-degree lateral corner. The head is secure in this position. I have much more place to bring my key wire in. It should be good. Yeah. I like to have my starting point for the key wire as much as proximal as possible to have a little bit space between the TMT1 and the screw head, but the point is fine. If you are proximal, you have much more possibility to tilt, to find the right direction. As much more you're going to distal, you're not able to get the head in the right position. There's always the question, key wire first or cut first. We are talking about this. Usually you can bring in your key wires first till this end, then you do your cut and then forward the key wires. This is in a mild pathology, okay. In some pathologies, you need the first metatarsal, the proximal part, to be tilted in a varus position to get a good position for your key wire. This is the reason why I cut first. You see this? If I bring the metatarsal more this way, I have a better place to get the key wire in than in a normal position. Yeah. Now I bring the key wire into the head. So I think I hit the other key wire. Yeah, but it's okay. The entry point for my key wire is as far as proximal as possible. Get it in here, get the second cortical about 1 centimeter proximal to the osteotomy. In the transverse cut, I'm happy with this X-ray. In a chevron cut, I would like to do a lateral X-ray to be sure that I don't have a lateral cut-off of my key wire. But this is the area I would like to have. So now I have for the screw, for the later screw, a good stabilization, and then go further into the head to the lateral aspect of the head and fix it. See if we're right. Yeah, we are midshaft. We are not plantar out. So now comes the second key wire, which is about 1 centimeter more distal to the first one. I try to be parallel, but sometimes it's not really possible. Makes no problem for me, but if it's possible, I try to have it parallel to the first one. Yeah, nice. Good. So the second screw is just one cortical here, and then in the cancellous bone. As soon as I have fixed this, I remove my key wire, which helps me to stabilize the position, and then I can bring in the drilling, the screws, and fix it. I start with the lateral one first and then the medial. In the open surgery, we usually cut off the medial exostosis of the head. This is not usually necessary in the MIS surgery. If you have a good enough shifting and there's enough space, you can leave it. So the benefit is you are always extra articular. But in some cases it's necessary, so you can go in through your osteotomy incision and cut it down, the exostosis, or you come over from more distal from incision and get it down. For this, you can use the wedge burr, which helps you to get off a lot of more bone. And then part which I always take off is this prominent part of the proximal to the osteotomy. This is quite easier for me to take it off from the incision of the distal screw, because I can go in and take off this exostosis. I start usually with a 2.2 30mm Shannon burr, where I create a space, and then I go in with the wedge burr to take off the amount of bone I would like to have. And you have to touch it, touch the foot, feel it. It's the amount which you have to take off. Take care about the second screw, the head. Usually you have a 3.0 to 4.0 screw there. So you have to take care by taking off the screw, the eminence, this area of bone. Don't hit the head, don't weaken the screw. You can avoid this if you take care of the position of the screw. So if you are as proximal as possible, you have more space later to take off this bone and to avoid this problem. And avoiding this problem is much more important to get the screw in the right position.